am going directly into my short study, which is differentiation of aplastic anemia from myelodysplastic syndrome using cell population data analysis on automated hematology analyzer. So, proper distinction of etiology of pancytopenia can often be challenging. Two main differential diagnoses for peripheral blood pancytopenia are aplastic anemia and myelodysplastic syndrome, presently called as myelodysplastic neoplasms. Myelodysplastic syndrome is usually characterized by hypercellular marrow with features of dysplasia in one or more lineages. However, in 10 to 15% cases of MDS, marrow is hypocellular. So this can pose a diagnostic challenge from aplastic anemia in the marrow. So the most commonly accepted method for assessment of dysplasia is microscopic examination of peripheral smear as well as bone marrow. Peripheral smear in the RBC can show macrocytosis. In the bone marrow, it can show ring sideroblast. Neutrophils can show hypogranulation, hypolobulation, pseudopelga-Huey anomalies. Monocytes are hypogranular, often with nuclei or nuclei containing nucleoli. Giant platelets can be seen. Circulating blasts are seen in the cases where MDS with IB1 or IB2 is suspected. Micromegakaryocytes or fragments of micromegakaryocytes also can be seen in the peripheral smear. But the usual problem with the peripheral smear is there is lack of reproducibility between the different observers. There is a technical problem and time of smear making after drawing the blood and the quality of the stain. All these can affect peripheral smear. So, assessment of dysplasia is very often subjective. So, cell population data analysis is a more objective way to assess dysplasia. Aim of my study was to utilize cell population data from automated hematology analyzer to assess morphological alterations of red blood cells, white blood cells and platelets to objectively identify dysplasia in myelodysplastic syndrome and to differentiate it from aplastic anemia. So, automated hematology analyzers, as various speakers have spoken, utilizes different principles like light scatter, electrical impedance, fluorescent light absorption, and electrical conductivity. Our own department has a study which found out that, as everybody else here knows, that conductivity or the granular light scatter is reduced in myelodysplastic syndrome when this was compared with the healthy controls. Mine was a retrospective study where we took 51 cases of aplastic anemia and 28 cases of myelodysplastic syndrome, wherein peripheral smear was also done along with the bone marrow examination, and we had access to the peripheral blood count. Peripheral blood samples were collected in EDTA and it was run in retic mode and WPC mode. Along with this patient sample, we also took 120 normal controls. MDS was made according to the WHO classification. Aplastic anemia was classified according to the severity of various cytopenias. These are various morphological features we usually get in the marrow, like dyserythropoiesis, pelga-Huey nucleoli, micromegakaryocytes or exploded megakaryocytes. And coming to the results, among the WBC parameters, we analyzed 13 indices and we found that site scatter and site fluorescence was significant between the two groups. MDS had a significantly lower site scatter of 141 compared to aplastic anemia, and it was also lower than the reference population. Site fluorescence was higher in aplastic anemia when compared to MDS, but it fell within the reference range. This is the plot showing neutrophil site scatter and site fluorescence. Among the RBC and platelet parameters, we didn't find any significant platelet parameters, whereas among RBC parameters, fragmented RBC and reticulocyte index in the y-axis, which is the site fluorescence of reticulocyte index, were significantly different. The fluorescence of reticulocytes were higher in aplastic anemia, whereas it was lower in MDS. But the fragmented RBCs were higher in MDS when compared to aplastic anemia. So we postulated that it might be because of the macrocytosis. Higher incidence of fragmented red cells, we thought that it could be due to macrocytosis accompanying the MDS. So these are the RBC indices which were significant between the two groups, reticulocyte size in the y-axis and the fragmented red cell. We also did the ROC curve and found out the sensitivity and specificity of all these parameters. We found that FRC and RETY had the best area under the curve of 0.839 and 0.833 respectively. FRC had a sensitivity of 85% and specificity of 80%. RETY had a sensitivity of 82%, specificity of 73% to differentiate between aplastic anemia and myelodysplastic syndrome. Neutrophil SFL and SSC had a sensitivity of 85 and specificity of 76%, whereas site scatter had a sensitivity of 75%, specificity of 84% respectively. So we concluded that cell population data analysis, that is decreased neutrophil site scatter and site fluorescence compared to aplastic anemia, can differentiate in the cell blood counter itself, which may be due to hypogranularity of the neutrophils. FRC was significantly higher, which may be due to coexisting macrocytosis. So cell population data parameters showed promise in differentiating myelodysplastic syndrome from aplastic anemia with good sensitivity and specificity. Thank you.
Thank you, Sreya, for that very lucid talk, yet in the shortest possible span of time that you could have done. One question before I set the ball rolling for the rest of the people to pitch in. Did you, from the data that you've shown, I obviously know that probably that's not the case, but just wanted to confirm from you, would you have done some megaloblastic anemia cases at the same time with this study? And, or have you done that, as a separate part?
We haven't done megaloblastic along with this. We didn't take any megaloblastic anemia cases. We excluded those cases, sir.
Okay. Yeah. My hunch is that if you do megaloblastic anemia cases, there might be a challenge between the MDS part of it, not the aplasia part of it, but the MDS part of it vis-a-vis the megaloblastic itself. There might be an overlap between your findings. That's my hunch. I will not be, unless we do it, will not be sure.